Good morning, everyone. Thank you for joining us today for the Monday Night IBD Improving Clinical Outcomes and Patient Satisfaction in UC. I'm Dr. Aline Charabaty. I'm the Clinical Director of the IBD Center at Johns Hopkins Hospital at St. Memorial Hospital. And I'm joined today by my colleagues and good friends, Dr. Millie Long and Dr. Miguel Reguiero.
Hi, welcome everyone. I'm Millie Long. As Aline mentioned, I'm at University of North Carolina at Chapel Hill, where I practice in our IBD center, and I actually direct our GI fellowship program. And I'm really excited to start this morning off.
Thank you, Millie. Thank you for being with us. I'll go to Twitter. Miguel, good morning.
Yeah, good morning, Millie. Good morning, Aline. It's great to see both of you. Sorry we're not all together, but I actually think that this new Twitter format is quite interesting, and we probably wouldn't be in the same room anyway. So my name's Miguel Reguiero. I think most of you know me, but I'm chair and professor of medicine at Cleveland Clinic in Cleveland, Ohio. And it's a great pleasure to be with the both of you today and all of you out there in Twitter land as we go through our morning of IBD education.
Thank you both for joining us. Our faculty disclosure are displayed on the screen. Our program today is the third in a series of 3 live stream programs about how we can improve the management of patients with UC. If you haven't done so already, make sure to check out the amazing tutorial that Dr. Reguiero posted earlier this week on Monday, January 25th under the Monday Night IBD Twitter handle. So today during our program, make sure to comment, tweet the questions. We will do our best to answer them live during this program and make our best to have a conversation on Twitter and off Twitter. Our goal today is to address how we can apply safety and efficacy data from clinical trials and real-world studies of new and emerging agents to achieve a personalized, patient-centered approach to UC management, how to interpret the updated UC guidelines by the AHA and the ACG to improve our treatment decision-making and care for patients with UC, learn how to evaluate potential approaches for positioning new and emerging therapies for UC, and finally describe clinical situation where novel therapies may offer an advantage for patients with complex or refractory inflammatory bowel disease. So today, the way we're going to divide our program, we're going to focus on different aspects of the care of our patient, Lucas, who has severe ulcerative colitis. We'll first talk about how to approach acute severe UC, what are the society's guidelines for that. Then we'll look at what are the treatment options available for our patients with UC who do not respond to infliximab or go into remission with infliximab. And then we will walk through what are the new and emerging therapy in the pipeline for ulcerative colitis and how to approach our patients with ulcerative colitis and inflammatory bowel disease in general in the COVID-19 pandemic era. All right, let's start with our patient, Lucas. All right, so this is a patient who's a 30-year-old man who was diagnosed 6 months ago with left-sided UC, moderate disease and with an endoscopic Mayo score of 2, so granular mucosa, loss of normal vascular pattern, a little bit of friability. But he did well with induction with prednisone. He went into remission, and then this was followed by mesalamine. However, he now comes with 2 weeks of 10 bloody bowel movement per day. And on FlexSig, his disease looks more severe. We now have superficial ulcerations and more friability that get him into a Mayo endoscopic score of 3. So we have more severe colitis at this point. On lab, he has anemia with a hemoglobin of 10. His CRP is increased at 17, and his albumin is on the lower side. So the first thing to do when we have a patient coming with a UC flare is really to assess the severity of this flare. What is the disease activity here? And the ACG put out new guidelines that really give you a nice global image or picture of the patient, because these guidelines now, these assessment tool take into consideration the clinical presentation in terms of number of bowel movement per day, blood in the stool, the presence of urgency, the presence of anemia or bleeding requiring transfusion, Inflammatory markers of biologic inflammatory markers like elevation of sed rates, CRP, fecal calprotectin, and what we're seeing on endoscopy, whether we're using the Mayo subscore or UCEIS, the UC Endoscopic Index of Severity. So our patients with more than 10 bloody bowel movement per day, continuous bleeding, continuous urgency, requiring transfusion, elevated sed rates, CRP, or fecal calprotectin, and with an endoscopic Mayo score of 3 was equivalent to a UCEIS of 7 to 8. This patient fit the description of acute severe UC, what we used to call fulminant colitis. I would like to go over what we're seeing on endoscopy, because I think this is important that the endoscopic score is being incorporated in how we assess severity. And I think it's very important to really incorporate that in our practice. Just saying that the patient has colitis or inflammation in the colon is not enough. Really describing what we're seeing and putting an objective number to the endoscopic severity is important, because this can help guide us into what is the best therapy for this patient, but also to have a baseline that we're going to follow and have an objective measure of response to therapy. So we're all familiar with what a normal colon looks like after a good bowel prep. And you'll see here that whether using this UCEIS or the Mayo score, there's some equivalence of how the colon will look, going anywhere from decreased vascular pattern, mild friability, to marked edema, to ulceration, spontaneous bleeding, really kind of grading the severity of the endoscopic activity. All right, so how are we going to manage our patient with acute severe UC? There are key concepts that were put out by the ACG, and one is always rule out C. diff. I think Millie was talking about this at the ACG course or AIBD, how we're not doing a good job ruling out C. diff in our patient with a UC flare. So always important to send stool testing to rule out C. diff. Perform a flexic within 72 hours of admission, preferably within 24 hours of admission, but definitely within the first few days, to really assess the severity, grade your endoscopic activity, but also to take biopsies and rule out CMV. And then whatever treatment we start, it's important to monitor the response to treatment in terms of number of bowel movement, physical exam, vital signs, the CRP, but also to monitor for any sign or symptoms that the patient is developing a toxic megacolon in terms of systemic toxicity and dilation of the colon. In terms of treatment, we start with IV steroids, and if our patient is not responding to IV steroids after 3 to 5 days, it's important then to move on to either infliximab or cyclosporine, and this should be really based on your experience in the center where you're practicing, the hospital where you're practicing or admitting your patients, based on albumin level, prior infliximab exposure, etc. And we'll talk more about this. But also it's important in terms of pain management or fever management, etc., to avoid medication that can either make the inflammation worse or increase the risk of complication or mask complication. So opioid anticholinergic can put the patient at high risk of distended colon, megacolon, or can mask a perforation or complication. Also avoiding NSAID is a good is a good thing to do that can, since NSAID could make the flare worse. Now, surgery. Always important to think about surgery when we're admitting our patient with acute severe UC. And the ACG recommend to consult surgery if the patient does not respond to IV steroid after 3 to 5 days. I'm curious to see what Millie and Miguel do, but I like to consult my surgeon early on so that the patient have the conversation with the surgeon and not have a surprise conversation later on. Of course, surgery would be indicated on an urgent basis if the patient is developing evidence of toxic megacolon, if there's severe hemorrhage, the patient needs to go for surgery immediately and not delay with trying more medical therapy. But what's important here is that there's often a concern if the patient has recently received infliximab or cyclosporine, but the patient require emergent surgery. Should the patient go, do we need a washout period? And what's important to realize is that being on infliximab or cyclosporine does not increase the risk of postoperative complication. So for a patient who's been recently exposed to this therapy, if the patient requires surgery, either because there's severe hemorrhage or no response or a complication, surgery should not be delayed. In addition to these key concepts, there are other recommendations put out by the ACG that I think are important to go over. One is DVT prophylaxis. Our patients with severe UC are at higher risk of DVT and PE. Important to start a DVT prophylaxis. If the patient tests positive for C. diff, vancomycin is a preferred therapy. It's more effective than metronidazole, so oral vancomycin is a treatment for C. diff in our patients with inflammatory bowel disease in the hospital or out of the hospital. When using IV steroids, it's important to use the right dose, not too low and not too high. Higher dose do not lead to better outcome. So methylprednisolone at 60 milligram per day or hydrocortisone at 100 milligram 3 to 4 times a day. Again, like we discussed, if the patient does not respond to steroid within 3 to 5 days, important to move to a rescue therapy. What the ACG recommended against is routine broad-spectrum antibiotics. So if the patient does not have an infection that requires antibiotic, routine use of medication like Cipro or metronidazole or other broad-spectrum antibiotic is not recommended. And also, routine use of TPN to put the patient in bowel rest and improve maybe healing is not recommended. It's strongly discouraged. Patients should be on a diet that's tolerable to them, and that also help you assess how the patient is doing on therapy. If the patient is not eating anything and not having any bowel movement and pain, is going to be really more difficult and to assess the effect of therapy. So it's important to use the gut for the patient, use the diet that they can tolerate during this flare. Next. The AGA also has clinical practice recommendation for managing acute severe UC that are very similar to what the ACG has put out, but also they touch upon whether or not accelerated or intensive infliximab use is valuable in some patients. This is an area where there's controversy in terms of data. Some studies showed no benefit in accelerated infliximab, and some show that maybe there are patient population that will benefit for that, and we'll talk more about this with Miguel and Millie later on. So let's go back to Lucas. Lucas does well on infliximab therapy. He actually did not respond to steroid and required infliximab therapy. And now his diarrhea is down to 4 non-bloody bowel movement per day. He was transitioned to oral prednisone. He's tolerating a soft diet, and we are thinking of discharging him. And the plan, of course, is to continue on infliximab to maintain remission while we're tapering down prednisone. And the question is, now that we started Lucas on DVT prophylaxis and he's improved in terms of his acute severe UC, does he need prolonged DVT prophylaxis on discharge? Okay, so this is a study that looked at patients with inflammatory bowel disease being readmitted for VTE after an initial admission for their inflammatory bowel disease. So patients with inflammatory bowel disease were admitted to the hospital, they were discharged, and then we looked at the patient being readmitted for VTE. And what we see here is that 90% of patients readmitted for VTE are readmitted within 60 days of their initial discharge. So it seems that the risk of VTE could be prolonged for up to 60 days after discharge for an admission for inflammatory bowel disease. Some risk factors for increased risk of VTE were identified in the study, including older age, comorbidities, a history of VTE, if the patient had prolonged stay at the initial admission, if C. diff was diagnosed at the initial admission, and if patients were discharged to a nursing facility or they require home health. So these are patients that are maybe have decreased mobility or who are sicker overall. So it's important when we look at the study to start thinking if our patients with inflammatory bowel disease require prolonged DVT prophylaxis upon discharge. But I think what's mostly important is to be able to risk stratify these patients and really identify who would benefit from DVT prophylaxis after discharge. So a few things to think about, probably for a patient who is young like Lucas, no comorbidities, who's ambulatory. I think it's important to at least educate our patients about the potential signs and symptoms of DVT and PE and let them know when to call and come back. If patients have limited mobility, it's important to provide adequate physical therapy after discharge. And in patients maybe who are sicker, comorbidities, history of VTE, severe mobility limitation, maybe these are the patients we need to consider for prolonged DVT prophylaxis, especially if they're also on therapy that have potentially associated with a high risk of VTE like Tofa. So here I'd like to actually take a pause and join my friend. I felt lonely with presenting these slides that All right, so Millie and Miguel, I have a lot of questions for you because Lucas behaved very nicely. He responded nicely to infliximab. We're able to discharge him. But I want to hear your thoughts about when and how do you assess response to steroid and infliximab? When do you start infliximab? After 3 days, 5 days, 1 week of steroid use? When do you think I need to start it almost right away? And then when you start infliximab, how and when do you assess response in terms of clinical symptoms, CRP? And when is the response good enough to discharge the patient? And on the other hand, when do you consider accelerated dose of infliximab? Do you have a specific patient subpopulation where you think this is a good option? And then if infliximab doesn't work, when do you say, that's it, I'm going to call my surgeon, you need to go to the OR? Or when do you say, let me try something else? Let me try cyclosporine, Tofa, something else. I would love to hear your thought. I know it's a lot of questions, but maybe we can start with you and then see what Miguel thinks.
Sure. No, I think this is an area where obviously further research is needed. We don't have great prospective data, particularly in the dose intensification of Remicade. However, let me tackle a couple of questions first. The first I'm going to tackle is, when do I start Remicade? When do I, if needed, when do I actually kind of try to assess response to steroids? And I really try to do that at the 3-day mark, not the 5-day mark. The other thing is that I really try to use as many objective measures as possible. And I would encourage you in your practice, if you don't already, to actually try to capture standardized data. What I mean by that is a daily CRP. Have the patient fill out a diary each and every day in the hospital so you can really see objectively, are the bowel movements decreasing? Is the amount of blood decreasing? Is that CRP coming down? If you really hit a plateau and that CRP isn't budging, that is a true indication in my mind to dose earlier with either cyclosporine or infliximab. You know, there is a non-inferiority study. There have actually been 2 that showed no difference in terms of induction for those 2 agents. And I really have had a resurgence in my practice of cyclosporine because of the ability to potentially induce with cyclosporine and then start something like Vettelism or even consider ustekinumab for maintenance. And so one of the things I'm using when I'm triaging that decision is what the patient's albumin is when they hit the door. Because if you think about it, and their albumin's already low when they hit the door, you're hydrating them, this is going to get lower and lower. And we know the pharmacokinetics of the anti-TNF agents such that when the albumin is low and they're that inflamed, they're really going to lose this drug in their stool and they're not going to mount an appropriate response. And so it's very hard to get that to a level where they're going to have efficacy. And that's a real area where I will consider the small molecule like cyclosporine to induce. And so the other thing I do, and this may be a little controversial amongst the 2 of you, but when I am using infliximab, I really like to use combination therapy. And I like to do that early rather than late because I'm very concerned about their level dropping and them developing immunogenicity just because of how inflamed they are. And I did notice, Aline, that you did not put Lucas on combination therapy. What are your thoughts there? When do you use that, and do you start it in the hospital?
That's a great question. And I don't believe I have started in the hospital. I think after the first dose, if there's a response, I always discuss with the patient that we're going to add immunomodulator. And I agree with you. The higher risk of developing antibody to infliximab is not only within the first year, it's within the first month. So we often have the patient who does well with the first dose, and the second dose, there's already an infusion reaction from antibodies. But I have been reluctant, actually. So I'm excited to hear that you're doing this, starting thiopurine with the high-dose steroids with infliximab in the hospital. I usually give the first dose, see how they're doing, and then if I know that they will do well with infliximab, then upon discharge, I start thiopurine. So I'm interested to see that you started from the get-go.
Well, Miguel, I don't start it day 1, no. But I do start it before they leave the hospital. Oftentimes, I'm making sure I have their TPMT. And you bring up a great point, which is when someone is on steroids, plus infliximab, plus a thiopurine or methotrexate, you really have to think about infectious complications. And that's also someone where I'm actually prophylaxing against pneumocystis jirovecii, and I'm giving them Bactrim, double strength, 1 tablet 3 times weekly. Because I have actually seen pneumocystis in my practice. We did a retrospective cohort study that showed this increased risk, particularly with the high-dose steroids combined with other agents, and also a very specific signal for calcineurin inhibitors. So that's the other thing. If I'm using cyclosporine, there by definition have been on steroids. So steroids plus cyclosporine, you don't need the third one. That equals pneumocystis prophylaxis as well, based on our data.
This is great, Miguel. I'd love to hear your thoughts. How would you approach acute severe UC in your patients? And do you do like Millie and kind of decide from the when you see them and stratify them by CRP and albumin, whether they would benefit from infliximab first or cyclosporine, or is infliximab still your first choice? And if infliximab doesn't work, is it safe for us then to move to cyclosporine or to a different therapy?
Yeah, so overall, so thank you, first of all. Aline, I think you did a great job of summarizing the data. And I think Millie and I practice very similarly, and Aline, probably you as well. The three of us probably do similar approaches. However, over time, I've changed a little bit in my practice, and I've had many Lucases over the last year or two. And if I'm true to myself, I'll tell you how I now practice, which is probably different than I did 5 years ago. So number one, I think when a patient's admitted to the hospital, this is a bad sign, and we need to do things very quickly. Ideally, you have the TPMT, TB test, hepatitis B, at your outpatient office that's already drawn. You have that set, so you don't need to wait on that. Number two is usually the first day we're doing an unprepped flexible sigmoidoscopy. You do not need to prep these patients. These patients are already auto-prepped, and you can very quickly get a sense of what their mucosa looks like. I'll use a pediatric colonoscope. If it goes very smoothly, I'll go to their ileum because I want to know if they need a pouch, what that looks like. But if it's very severe, you can stop in the left colon, you get your answer. Number three is I don't wait 3 days anymore. I think these are patients sometimes that come in on oral corticosteroids, or they're sick enough that if we can by day 2, and day 3 is reasonable, don't get me wrong, we're using 10 milligram per kilogram infliximab. There are no data that 10 milligram per kilogram infliximab or accelerated dose changes colectomy rates at 1 year. However, short-term data in my personal experience, that's what I do. Number 4 is, to Millie's point, actually I used to always put them on a thiopurine when they left the hospital. Now I'll give 1 dose 10 milligram per kilogram. 3 or 4 days later, if they're responding well, I ignore that first dose and give a 3-dose induction of infliximab as an outpatient at 10 milligram per kilogram. So I stack, and I'll do a post-induction level. And actually, I've found a couple of my patients, actually one I just saw yesterday, a physician who has a great level. 1 year later, he's not on combination therapy. So it gets into the proactive monitoring. The final point I'll make is that what's your exit strategy is obviously imperative, whether it's cyclosporine first, infliximab first. More and more, honestly, these patients, and I think something, whether it's environmental or something has changed, these young male patients are very sick. If they fail their first agent, whether it be cyclosporine or whether it be, I usually give 2 doses of infliximab, 10 mg per kg, 3 to 5 days apart in the hospital. If they fail that, the surgeon's seen them from day 1. They're following along, like Millie said, they're on DVT prophylaxis, which is imperative. And if they're not getting better, they go to surgery. If they improve, we continue as an outpatient. The role of tofusetnib, high dose, the University of Michigan group has presented some of their data. I don't do that yet. I'm still waiting. I think that's an interesting concept. It's not something I've done yet. And I'm still using infliximab more than I am cyclosporine.
Mm-hmm.
This is fantastic. We're seeing a different way of approaching.
I do agree, if you're going to use an accelerated protocol, that we do something similar where we actually will dose that second dose before they leave the hospital. but we really only count that as one dose, I'm still bringing them back, within 2 weeks for that second dose. And so the idea is those first 2 stacked doses are probably only getting you to a therapeutic level of 1 dose standardly. And so I think it is important to do so and to recognize the pharmacokinetics of the drug. I did want to comment on one other thing that Miguel said about DVT prophylaxis. It's so important, and we're not universal about this. And I think some of it is, for example, at my institution, the residents get worried because they're having rectal bleeding, and so they don't want to put them on DVT prophylaxis. And so just if you can make it a part of your standard orders, I think it helps because it gets implemented more often. And the other thing I would note is I do think, and we do know that more of these individuals are men who come in with this acute severe ulcerative colitis, but if it is a woman, I really think about her contraception, because this is a high risk time to be on an estrogen containing oral contraception. And I will stop that when they leave the hospital because I don't want them to have dual risk factors for clotting. And that's real. I have seen that in a few patients where they've come back with a clot and they've been on oral contraceptives. And so I just put that in your brain, something else to look for.
So two lightning fast comments. I know Aline's looking at the clock and saying we're never going to get through this. But
I'm enjoying it. I have nowhere to go. It's cold outside. I'm really enjoying my morning with you guys.
Grab some more coffee.
Great things that we don't see, right? These are the things that we don't see in guidelines and in articles, and this is what experience and seeing many patients who are sick, just all in one room. It's fantastic. Please keep going, Miguel.
Yeah, no, but just 2 brief comments. I now have evolved my practice, kind of like Millie said, but I actually, for those out there, and from an insurance standpoint, infliximab has generally been easy to get approval, and biosimilar infliximab to me is fine. And actually, Cleveland Clinic, that's probably what we use almost exclusively. Whether they receive 1 or 2 doses in the hospital, I actually ignore those. That to me, when I tell the nurses to get the approval, whether they've had 1 or 2, once they get the outpatient approval, which usually within a week or 2 of them leaving, I'll give that 3-dose induction again. So they may have 4 or 5 doses very quickly. And I think it's our best shot of improvement is an induction with all the medicines we have. The final thing on DVT, and Stefan Holobar, who's a colorectal surgeon with us at Cleveland Clinic, and others are looking at this. It's interesting and a little bit scary to see the rates of asymptomatic DVTs on Doppler ultrasounds and some other studies is very high. So I completely agree with what Millie said. And that's something that's, Aline, your question. We're wondering if we do continue a month after they leave the hospital on DVT prophylaxis. I'm not uniformly doing that yet, but I think I might evolve my practice. So next time you have me back next year, I might tell you I'll be doing that differently as well.
That's good. It's all, we keep on learning and modifying because, these are patients that are difficult to manage, and there's always progress to be made in order to improve outcome. Well, thank you. This was a very exciting conversation. I learned a lot in a few minutes. So I appreciate all the input and the tips and tricks. And, what I take away from this conversation is if you're going to use accelerated dosing of infliximab, if you do it early, as soon as 2 to 3 days, start your first dose at 10 milligram per kilogram, another dose after 3 to 5 days, and consider that as 1 dose. And so reinduce or complete the induction on discharge. DVT prophylaxis is something very important and to think about really assessing the risk factors for patients, including the typical risk factors of DVT, comorbidity, decreased mobility, history of VTE, but also, Millie, you bring up a great point about estrogen-containing birth control pills, something we might not think about frequently enough in young women. And then timing to start immunomodulator. So whether upon discharge, sounds like most people, you would do it when you're discharging the patient. Miguel maybe relies more on proactive drug monitoring, checking level, making sure we're at the right level, there's no antibodies. If there are antibodies, maybe add the immunomodulator then. If not, optimize the drug level with the dosing and the frequency of infliximab. And overall, not delay surgery. I think this is what I'm hearing also, which is also my practice. And it's always about the discussion we have is we're trying to save the patient and not the colon only. But I'd like to take that opportunity to go over what other therapies besides infliximab are being used. Millie, I'm excited to see that you are thinking more about cyclosporine. And I agree with you, we have to start thinking more about non-infliximab therapy because sometimes we're admitting patients with acute severe UC who've already been on infliximab, who are on infliximab and losing response or no response. So even though infliximab has always been our, well, you know, in last many years, being our go-to drug for acute severe UC, it's important to start thinking outside the box and become familiar or comfortable again with older drug like cyclosporine, or maybe get more experience with tofusetnib. So I'd like to go over some of this data, and then we can meet again. All right, so like Millie was saying and sharing with us her experience with IV cyclosporine, it's important to consider in patient where you think infliximab is not going to be a good option. So whether they've been on infliximab before, or if they have a low albumin, high CRP, these are the patients we know are just going to poop out infliximab in their gut. We're not going to be able to achieve a good level to induce remission. IV cyclosporine is given as a continuous drip with IV steroids. It's important to prevent complications such as PJP, important to provide prophylaxis, like Millie pointed out, and to check for trough level at 48 hours with a goal of 300 to 400. If the patient responds to IV cyclosporine, this is when we're discharging them on oral cyclosporine with a prednisone taper, and again, thinking about exit strategy. Traditionally, the exit strategy has been azathioprine. This is how the original study looking at cyclosporine managed patient, and now we're thinking, like Millie was saying, Vettelisumab or secukinumab as an exit strategy. In one of the first studies looking at cyclosporine from University of Chicago, around 40 patients were placed on cyclosporine. There was 86% response. 60% avoided colectomy at 5 years, which is very similar to what we see when patients respond to infliximab. And when patients require colectomy, this happened in the first 18 months after initiating cyclosporine. Next, let's talk about use of cyclosporine as a combination therapy. We talk a lot about thiopurine as a combination therapy with infliximab, but again, this is data from University of Chicago using cyclosporine or tacrolimus in combination with vedolizumab with the goal to transition the patient to vedolizumab monotherapy. I just want to point out that these patients included UC patient and Crohn's patient with active disease. And you can see it to your right, on the graph to your right, that as early as 14 weeks, patients had decrease in disease severity. The colitis activity index dropped significantly and remained low in patients who responded to this therapy. If you look at the end of a year at week 52, and look at steroid-free remission, you see that 45% of patients achieve steroid-free clinical remission with this combination therapy. And in this study, at the end of a year, around 45% of patients remain on vedolizumab and doing well. So this is one option that you can think of in your patient, maybe who lost response, failed infliximab, and then you're trying to manage their disease activity and transition them to a different biologic therapy. And finally, let's talk about Tofa. And Miguel pointed out to some smaller studies, small case report, looking at using tofusetnib in patients with acute severe UC who are not responding to steroid and who had not responded or lost response to more than 2 biologic, including infliximab. And here we're using a higher dose at what is FDA approved, looking at 10 milligram 3 times a day. And in these 4 patients, there were rapid symptom improvement and drop in CRP. Upon discharge, all 4 patients were discharged without needing colectomy, and they were placed on a Tofa maintenance dose of 10 milligram twice a day and a prednisone taper. At 90 days, there were no colectomy and no readmission, and 2 out of those 4 patients achieved clinical and endoscopic steroid-free remission, and there were no major side effects. So it's important to start thinking outside the box in some patients, but I think the selection of these patients is key here and very important, because what we're going to see with the next slide is that the longer we delay surgery, the more we're putting the patient at higher risk of complication. So when you're assessing your patient with acute severe UC or severe UC, it's very important to balance and to assess the benefit we're going to derive from different therapies when the first or second one have failed versus not delaying colectomy. So this study looked at major complication and after surgery for acute severe UC after colectomy. And we see here that there's an increase in the risk of complication the longer we delay surgery. So the longer we're using medical therapy and delaying the surgery, the more we're putting the patient at higher risk of complication after colectomy. And these complications included wound infection, wound dehiscence, small bowel obstruction, pneumonia, sepsis, intra-abdominal abscesses, high ostomy output. So all kind of major complication can be increased in patient where we delay surgery. So I'm going to bring our panel back together. And I think we had a very lively conversation first. So I just want to have, a short thought, when do you try more? When do you go for surgery? When do you optimize? In a patient who has partial response, when do you add on combination therapy? When do you move out of therapy? And again, just, we don't have to go through, we're going to go through more information later on, but just wondering your thoughts about all this. When we have now so many different options, I think, when we all started taking care of patients with UC, if they didn't respond to surgery, they went to steroid, they went to surgery. Then we had infliximab. Now we have more options. When do you consider these options? When do you consider sending the patient to surgery?
I'm not sure. I guess I can go first on this one.
Go with Miguel this time.
Break it into two scenarios. One is the patient in the hospital who's still sick and unable to improve after, whether it's cyclosporine 3 to 5 days or infliximab 2 doses. To me, that patient needs a colectomy. To your last point, we should not linger. That's a patient needs a colectomy. The more challenging patient is the one who improves, leaves the hospital, starts to taper steroids, and is not still has high CRP, fecal calprotectin is high. They're not quite where you want them. And if their levels of infliximab are good, for example, then it's a heart-to-heart with the patient. If they adamantly refuse surgery, which is usually, quite honestly, what I'm pushing at that point. But if they adamantly refuse after infliximab, to me, my next go-to is Tofusetnib, and I'll use that at the 10 milligram twice a day. We obviously go through all the risks, and we can talk about that separately. But that's the one that would go to Tofa or a colectomy if they failed infliximab and have good levels.
Mm-hmm. That's a great, I think it's good to kind of categorize patient, how sick they are and what kind of response we're having. So Millie, if let's say our patient here has good infliximab level, like a trough level of 15, is overall doing well, but when you get him to a prednisone of 15 milligram, he start having symptoms. His fecal calprotectin is like 250, 300. Is this a treatment failure? Is this someone who you would consider even increasing the dose of or frequency of infliximab or adding immunomodulator? Or is this someone you say, you know what, this is not working, time to move on, maybe consider Tofa or other therapy like Miguel said?
Right, and a lot of it does depend on that drug level. I think that's very telling, as well as the patient's overall clinical response. How well did they really do initially, and where are they now? And actually, Aline, you asked me this question, but I have a whole section of slides that might give us some answers to this. If you want me to move through that, that second therapy, which is the post-TNF patient, whether a primary non-response or a secondary kind of loss of response, what should we be considering in that scenario? And I think that is what happened to Lucas in our presentation. So would you like me to move forward with some of the data and then we can come back?
I skipped the slide, but I'm glad you're on target.
So this is a nice algorithm that looks at ulcerative colitis when you have loss of response or non-response to a biologic. And really, in my practice, and certainly in a scenario such as this, where the patient was initially acute and severe, that is often a TNF up front. And I think that one key aspect here is there objective evidence of ongoing inflammation? Remember that sometimes not all symptoms are equated with active inflammation, and that particularly particularly in a situation where a patient had done well and then started to relapse, understanding the severity of that inflammation, whether it's present or whether you may need to deal more with a visceral hypersensitivity, or sometimes motility can be affected in longstanding UC. Try to really understand that it is inflammation. Rule out infection, as we talked about. Certainly we'd want to treat concomitant infection. And then the idea of really differentiating between primary non-response or secondary loss of response. If it's truly a primary non-response, this person never got better with that agent, you absolutely have to switch out of class, and actually surgery should be considered in all of these algorithms. Once someone has been initiated on one biologic, that's when they have not responded to that biologic or they lose response. That is when I am having them meet with the colorectal surgeon. It's not once they've failed 2 or 3. This really needs to be an active option earlier in the course. They feel educated, they feel established with colorectal surgery. If they have a secondary loss of response, meaning initially they did well and then at some point lost response, certainly that's a role where reactive therapeutic drug monitoring is evidence-based and recommended by all of our governing organizations. If they have a very good drug level and no antibodies, I would consider switching out of class. Although I'm sure Miguel and I will talk a little bit about this, I do think in some instances there could be a role for considering a second TNF in that scenario if they initially responded to the first. If they have a low drug level, that's obviously where you optimize and increase. And then if they have no drug detected and high antibodies but initially responded, that's clearly where you would switch within class. But remember that once someone has developed immunogenicity, you really know that they're going to have continued immunogenicity, particularly with the TNF class, and you absolutely need to use combination therapy in that scenario. There are actually some interesting newer data out of the PANTS consortium that there may be a genetic marker, HLA-DQA105, which has recently become commercially available, that may be associated with increased immunogenicity to anti-TNF, and that may be a means early on to help us determine who really needs combination therapy up front. So next slide. So these are the data on Vettelism and ulcerative colitis, and I'm just going to go through these quickly in terms of our classes because you're going to see the similar theme throughout, which is in the left panel, it shows the TNF naive data, where you see an absolute number of 53% for response at week 6 and 46.9% for remission at week 52. But when you look over on the right-hand panel, you'll see that while the delta is fairly similar, the absolute response and absolute remission is lower. And this is not unique to Vettelism. Next slide. We see something similar associated with ustekinumab, where again, in the bio-naive population, we're seeing very robust response and remission rates. And then in terms of bio-failures, we are seeing a drop-off here, about 10% in each category. Next slide. For Tofusetnib, again, on the left, you'll see the Octave data, Octave 1 and 2 and Sustain, where at week 8, you see a marked difference in terms of remission there. And then at week 52, again, quite impressive in the no prior TNF failure population. But among those with prior TNF, while the delta overall is similar, the absolute value is lower. So again, this population of prior TNF exposure being a very difficult to treat population, or obviously, potentially, there's the hypothesis that the TNF may be changing some of the biology of the disease. We don't have too many trials that go the other way, where they start with a different agent. And so I think that this is something we need to take into consideration. Next slide. These data, I think, are very important. And so, like Miguel, I do use a lot of Tofusetnib post-TNF failure populations. I've seen efficacy in my own practice, and I'll show you some of the real-world data. But I think one thing that becomes very important about Tofusetnib is what do we need to do associated with maintenance? So as you all know, the dose for induction is 10 milligrams twice daily, and that should be for at least 8 up to 16 weeks. And then after that, we need to maintain them on the lowest dose possible to maintain remission. It doesn't mean we have to do 5 twice daily, but the lowest dose possible to maintain remission. And so I think the riveting trial, the data were presented recently at UEG, and I wanted to share them with you because they haven't been presented as obviously in the US, and I think these have really informed my practice. So this was a phase 3b4 double-blind randomized control trial of efficacy and safety of Tofa dose reduction. And importantly, this took 140 patients who were in the open label extension for over 2 years. years who are in a stable remission. So this is the best case scenario. You know, when we're doing it in clinical practice, we're asked to look at this at 8 to 16 weeks. No, these are patients completely stable, no steroids for the prior 6 months. And then they were randomized to dose reduction or maintaining at 10 milligrams twice daily. From a safety perspective, it was actually quite similar. There was no increase in cardiovascular events, malignancy, non-melanoma skin cancer. There were 3 zoster cases with the high dose, 1 with the low dose, and 1 PE with the high dose. But next slide. There were significant differences associated with efficacy. And so when you look at this chart, overall, the clinical remission rates at 6 months were 77% in the 5 milligrams twice daily versus 90 in the 10. But I'd like to direct your attention to 2 particular rows. The Mayo endoscopic score of 1, meaning if these patients were in clinical remission but still had some evidence of inflammation as defined by some erythema in the rectum, there was a marked difference, over 20%, in terms of whether or not they would maintain remission. So in other words, the people on 10 milligrams twice daily did much better. The other category to look at is the bottom row, which is prior anti-TNF. And here you're again seeing about a 17% difference, where those with prior TNF exposure, which is 100% of the population that we are treating here in the US, there was a pretty marked difference in terms of maintenance of that clinical remission with the higher maintenance doses compared to the lower. So I'll be very interested in seeing what my colleagues' practice has become. But I will say in my practice, I am using a great deal more of the 10 milligram twice daily dose for maintenance, because so many of my patients fit in these categories where they have very severe disease, they'd had prior TNF exposure, and I may not have healed them 100%. They may have a Mayo score of 1, but they are in clinical remission. So I consider that a victory, but it's a slippery slope if we dose reduce. So I look forward to that conversation. Next slide. I also want to share with you some real-world data that have started to come out from Tofusetnib practice. And so this was a UK retrospective study of over 100 patients. And they looked at overall response rates with Tofusetnib as well as remission and steroid-free remission. And what they found is that they had about a 44% steroid-free remission rate at week 26, which is actually pretty good in a refractory population. Primary non-response was actually associated with younger age and higher CRP, markers for more severe disease, but not necessarily with prior biologic exposure. And again, with this cohort, they saw about a third recurrence with dose reduction, and importantly, less than half of those recaptured response with dose escalation. So it's not that by going straight back up to 10 milligrams twice daily, you recapture everyone. And obviously, the next step for many of these patients is colectomy. So I think we need to make that decision carefully and in an evidence-based fashion. Next slide. These are some data, again, from the INIDA registry out of Spain, which looked at over 100 patients with ulcerative colitis. They found a 60% response and 31% remission at week 8, which, again, in a pretty refractory population. And that 65% of patients in remission at week 8 did relapse after dose reduction, again, informing us of practice patterns and what we should be using from a maintenance perspective. Next slide. And so these, again, this was a somewhat smaller cohort, again, on real-world efficacy, which show us similar rates of kind of biological remission, biological response, and that the people who've been on multiple TNFs previously, those people seem to have a little bit higher rate of primary non-response to the Tofusetnib in this small cohort. The predictors of endoscopic response included a higher baseline albumin, which likely is associated with somewhat less severe disease, I would argue, and a reduced baseline endoscopic Mayo score. Next slide. And so when we think about the safety, these studies have also informed us on the safety of Tofusetnib. Again, the numbers are still relatively small, but this experience is really increasing. The number of patients with adverse events in the INIDA registry was similar to other agents. You know, certainly it's something where we're monitoring cholesterol. They did have 1 herpes zoster, some various infections. There was 1 neoplasia. And then in the UK study, certainly worsening of UC is a known adverse event if the drug is not effective. Again, some lipid panel abnormalities. But in neither of these studies, and again, numbers are small, but there are very reassuring data thus far that we're not seeing DVT and PE risk. And that's something that I know our panel will talk about, given the recent top-line results from an RA study associated with high-dose Tofa as compared to low-dose Tofa or TNF, where there was a signal for increased DVT, PTE risk, as well as increased mortality. Again, not our population, but something that we're trying trying to better understand in ulcerative colitis. Next slide.
Thank you,
there we go.
Efficient and wonderful. Thank you. So actually, let's start from where you ended, and then I'll ask you more questions. So what is your approach, and how do you approach your patient? What kind of discussion you're having with a patient when you're talking about Tofa, and we're having all the news coming out about potential risk for DPE? And I understand we're not seeing this in our patient population. The randomized controlled trial didn't see an increased signal. The data you presented, real life, real world data also does not show a signal in our patient with UC. We know that severe UC itself is associated with a higher risk of VTE, DVTs. So how do you discuss this with the patient and reconcile the different data? And is there a patient population where you say, you know what, I'm not going to consider Tofa because of the potential risk, or I'm going to do something different?
Sure. Yeah, I'll speak to it briefly, and then obviously loop Miguel in as well. But for me, I'll take the last question first, which is anybody with a history of any kind of clotting disorder, I'm not going to use Tofusetnib in. Any patient who has a history of prior DVTs, I'm also worried because there is a risk factor of subsequent DVT in someone with that prior history. So those are patients who I'm going to try to go with a different mechanism. Otherwise, I have a conversation patient about the study, the population it was in, and I try to minimize other clotting risk factors. Again, here's a role where oral contraceptives with estrogen may not be the best. I actually will recommend progesterone-coated IUD for contraception for those individuals because you don't have the systemic estrogen component. And this is yet another reason to get people to stop smoking. So I try to modify modifiable risk factors and counsel patients appropriately. But I do use this drug in this scenario. And, I counsel patients about travel, extended rest, kind of the typical things. But most patients are willing to understand the data and are willing to move forward, particularly with the great benefit of kind of a lot of them are teetering on that edge of really needing surgery.
Right. How about you, Miguel?
So I agree with that. The added points that I'll make with Tofusetnib is I actually talk about the increase in cholesterol, which is not something that we're worried about, but I mention that to them because that has come up with some of my patients. And probably the most important risk factors we see is shingles, is zoster. And so again, the vaccination with Shingrix, if possible. It's not always possible, and I acknowledge that. But that's probably the risk factor that I'll point out to them the most. Nonetheless, as the three of us, I'm sure, practice similarly, I don't belittle or underestimate the importance of DVT and PE. So I tell them that although the data were in rheumatoid arthritis over the age of 50, cardiovascular risk factors, that because ulcerative colitis has a higher risk of DVT, regardless of the medicine that they're on, that if they get calf swelling, shortness of breath, I emphasize that is absolutely imperative for them to contact us. So I agree with both of you. I tell them the Tofa data looks very good and probably not concerning in UC, but clots in UC itself are a concern, and we need to watch out for those independent of the medicine. So it's just a way for me to bring that topic up with them.
Mm-hmm. Absolutely. So if I hear correctly from both of you, a certain patient may avoid Tofa if there are other options. If this is an option needed, really take out all the other potential risk factor for VTE, but very important to educate all our patients, whether it's Tofa or no Tofa, educate all our patients about the risk of VTE, and with Tofa, educate about other potential side effects that we need to monitor or prevent with vaccination, including zoster. I personally have, I've had patients who kind of older, but, lost response or did not respond to multiple biologic, and we're very still reluctant to go for surgery, or we're not good surgical candidate. And again, this whole VTE risk was, something that came up, especially in an older person with decreased mobility. And what we decided to do in some of these patients is use a lower dose, and patient did well. And I think it's always important to discuss that risk and the benefit. And really, as long as the patient is aware, and the patient is aware of the other options, including options of surgery, and they decide to go with a therapy and understanding the potential risk and the sign to look for, I think this is the best we can do at this point.
Yeah,
My
just
next question.
the one very, very, very brief thing about Tofa and the dose. So everybody knows in the label there's an attempt that should be made at 8 weeks to lower to 5 milligram twice a day, unless they've had an incomplete response, and it's 16 weeks. I will tell you, despite that, in my personal practice, the majority of my patients I cannot lower to 5 milligram twice a day, and they are staying on 10 milligrams twice a day and doing extremely well. So I just want to emphasize, I agree with lowering the dose, but I don't see that that's always possible in our patients.
I agree. And I think all of us, like you said, Miguel, practice very similarly. And Millie just showed us, very compelling data that often our patients who are started on Tofa, they have lost response or did not respond to other biologic. And these are patients that really would benefit from remaining on 10. So when I start on 10 and I see a response, I stay on 10 also. So my next question is, I think that gray zone, when is it when the patient doesn't go into remission with a therapy? Let's say we did Lucas, for Lucas, he was on infliximab, he responded, but couldn't get off low dose of prednisone. But now Lucas has a lower inflammatory burden. Would that change what would be your next step versus a patient who is still as severely active as the initial presentation? So when we think about the next step therapy do we have to kind of look back how the patient presented? They required steroid, maybe they had C. diff, they were in the hospital, or do we also need to take into account where we are now? They started with severe disease and might have a milder disease. Is that determine what kind of therapy would go for next versus if they continuously have severe disease? Does this really get into play? How can we kind of put everything together, the current activity and the prior history, and how does this change your approach? And Millie, since you just presented so elegantly the data on the different therapies, I'd love to hear your thoughts first.
Sure. So I think we have to consider both, as you mentioned. The new ACG disease severity index takes into account not only the prior history and the risk factors the individual has, but also how they're doing now currently. So I consider both. In this scenario, Lucas is now steroid responsive, right? I mean, as long as he's on steroids, he's okay. So that's a very different individual than someone with acute severe ulcerative colitis. So this isn't necessarily someone that I need to jump to cyclosporine right now, right? So this is someone who you could consider Tofusetnib, you could consider ustekinumab, you could consider Vettelism, because you have that bridge, in terms of the steroids that he is responding to. And there's no right or wrong answer there in terms of which you choose. You really have to discuss it with the patient and talk about the overall efficacy and safety data, as well as, onset of action, those sort of aspects.
I agree. How about you, Miguel? How do you kind of stratify a patient who has either maybe lost response or was a primary non-responder? How do you, does this affect your next treatment choice?
Yeah, no, and I think it does open the option to Vettelisumab and ustekinumab. I think, to be quite honest, these are probably the most challenging patients because they have improved, but they are not in remission. And I get worried because these are the ones that stay in limbo for a number of years sometimes. And these are the ones, quite honestly, that you see dysplasia, potentially cancer down the line. So what I tell them is, no, they don't need an emergency colectomy, although that is a very reasonable option. Good levels of infliximab, still active inflammation, still on a low dose of steroids, although, like Millie said, responsive. However, then I think you do have the option of Veto or ustekinumab, or certainly Tofusetnib, which we talked about quite a bit. And then we go through, again, the different mechanisms. Are they preferable to an IV, Vettelisumab? Would they rather something that's an injection every 8 weeks after an infusion, ustekinumab, or Tofusetnib pills? So sometimes it comes down to the decision on what is their lifestyle. Are they traveling a lot? Is it hard for them to manage this? If their albumin is still low, I would probably tend away from a monoclonal antibody for the reasons Millie said, and then I would go to a small molecule, which right now is only Tofusetnib.
I agree. So just to summarize what I'm hearing, assess the prior history, because that gives us a long-term prognosis on how the patient is going to do, reassess what is the current status of disease activity and response to the current therapy. And again, that these are the gray zone patients that we're presenting today, where they're not, not responding, but they have a partial response and now becoming like requiring a low dose of steroids to do well. But we do need to do something different. So reassess how we're doing now and really take into account other medical history for the patient preference, patient social history, patient pregnancy planning, other comorbidities, other medical history, etc., and really have that shared decision making with the patient and pros and cons. And sometimes, like you said, Millie, there's not a right or wrong answer, and that's why we need to have these conversations and hopefully more studies to help us have the right or wrong answer that will make our life easier and job easier. But these were all great points made by both of you, so I really appreciate that. So Millie, I'm going to let you wrap it up and tell us over the next few slides how we can approach things, how we can put all this together between the recommendation and our patient experience, and then we'll move on to Miguel's part.
So again, I'll just briefly go over this. I think Aline mentioned that we don't have head-to-head data necessarily of one agent as compared to another, other than the Varsity trial, which of course compared adalimumab to Vettelism and did show superiority of Vettelism in that comparison. But we have some indirect data, and I'll show you both in the overall population and also in the biologic exposed population. And by indirect, what I mean is these are network meta-analyses where they indirectly gather the data from the various clinical trials, pull it together, and try to make indirect comparisons. It's not a high level of data, but it can help kind of in a hypothesis generating fashion for us to position some of these agents. And I think it's probably no surprise to anyone on the call that infliximab probably has the highest efficacy when you compare things indirectly. And that when you look at prior TNF exposure, it seems to be tofusetnib and ustekinumab that seem to have better efficacy, again, using these indirect data. Next slide. And so the ACG recommendations for patients with moderate to severe UC, we talked about all these agents, all of them are available in terms of induction, and that we should consider combination therapy with infliximab. We talked about reactive therapeutic drug monitoring, and that at the time of this statement, we did not yet have the ustekinumab data, but I would argue that ustekinumab, Vettelism, or tofusetnib should be included in previous TNF exposure. Next slide. The AGA actually came out with a low strength recommendation that in those with previous infliximab exposure, particularly with primary non-response, that ustekinumab or tofusetnib should be considered rather than Vettelism or adalimumab, again, based on that network meta-analysis data. Next slide. And so just one additional point is that, the ACG guideline made it pretty clear that we recommended combination immunomodulator associated with infliximab, but that statement was not necessarily there with Vettelisum or ustekinumab. And when you look at duration of therapy associated with monotherapy or combination therapy with these two agents, we see that these curves actually overlap quite considerably over the course of a year, meaning that we may not have the added efficacy associated with an immunomodulator addition with these two agents. Next slide. So this is my last slide, and then I'm going to turn it over to Miguel. But I think that what this is meant to emphasize is that we really need to consider a personalized approach and the individual characteristics of each patient in terms of considering what their next therapy may be. So, in someone who has significant extraintestinal manifestations at baseline, I would consider a TNF. If they value convenience or not coming in for infusions, certainly we have some subcutaneous options. Thinking about older individuals, we think about Vettelisum or ustekinumab based on their rigorous safety data. History of cancer, again, Vettelisum due to its gut specificity. If they have concomitant joint symptoms, whether RA or psoriatic arthritis, I really am thinking about a TNF in that scenario. And with psoriatic arthritis or psoriasis, ustekinumab is a great agent. Primary non-response to a TNF, again, any of these agents we talked about could be an option. And pregnancy planning, I do want to emphasize this one, that the Piano registry was just published in Gastroenterology gastroenterology, and it shows robust evidence that any of our monoclonal antibodies are very safe during pregnancy and actually improve outcomes by limiting preterm birth and complications of disease activity. So at TNF, Vettelism or ustekinumab in those populations. We don't have enough data yet on Tofusetnib, so I'm not using that in my pregnant patient population. So let me pass it over to Miguel.
Great, Miguel, we're gonna quickly pass it over. And I think the main thing here is when we're having a patient who had who've been on one effective therapy, second effective therapy, I think the question that we often get from patients, and we all started worrying also, is what's next? What happens if I don't respond to any of the therapy or I keep losing response to therapy so quickly? When do you consider clinical trial? When do we consider surgery? And I'm looking forward to hearing from you. What is in the pipeline for our patients with UC?
Great. So I'll talk a little bit about some of the new therapies that are coming, but also touch on COVID because I think that's an important topic as well. And one just brief editorial comment, a colectomy and surgery is not wrong. And I think the three of us have said that repeatedly. So if you have a patient who's failed one, failed two therapies, you're thinking about a clinical trial, that's not incorrect, but I would also really consider a colectomy. So let's talk about some of our newer approaches. Maybe in the next slide, we can get into the different mechanism of action. This is a busy slide. You've seen variations of this at other conferences, I am certain, but this is just really to show you that the pipeline for IBD therapies and specifically ulcerative colitis is really an exciting time. There are many options that we have looking at blocking different cytokines, selective blockers, getting into trafficking, intracellular signaling, and then also just generally this new concept of other small molecules that impact lymphocytes and lymphocyte trafficking. So why don't we go ahead to the next slide? So this is looking at now selective inhibition of JAK. And the reason this is coming up is the question is, can we actually use a selective JAK1 inhibitor? Upadacitinib is one of the options, and I'll refer to it as UPA. This is actually something that would potentially provide us a higher ability or higher dose of a selective agent, possibly with the concept being improved safety. And you can see in this slide, on the left-hand side is clinical remission. On the right-hand side is endoscopic improvement for different doses of UPA compared to placebo. And I won't go through each of the numbers, but you can see somewhat of a dose response with a higher benefit in at least remission and certainly with endoscopic improvement. Next slide. And the safety of upadacitinib has actually been looked at 8 weeks. This is the U-Achieve study, and you can again see the standard safety table that we present at many of our conferences. And for the most part, you can see a pretty good safety signal, meaning that we're not seeing anything with the UPA data. Possibly at the high doses in one patient, we saw a cardiovascular event, an infection, but nothing that we haven't seen with any of the other studies. So the safety looks excellent for UPA. Next slide. So aside from UPA, what's on the horizon? And the S1P modulators are to come. Ozanimod is one currently approved for multiple sclerosis. This is the True North induction study looking at week 10. The blue bars are for the active treatment with ozanimod, and the gray is placebo. You can see that patients prior anti-TNF on the left-hand side, no prior anti-TNF on the right-hand side. And you can see actually a nice response for the ozanimod over placebo for various endpoints, specifically looking at clinical response. And then also if you imagine that this could potentially be first-line agent, not secondary to anti-TNF, because if you look at the left-hand side, you can see patients who had already been on an anti-TNF don't seem to respond as well as they do to bio-naive or no previous anti-TNF. So looking at the right-hand side, you can actually see a robust response for ozanimod. This is an oral medicine, very exciting, and still to come, but probably pretty soon. Next slide. And looking at the safety data with ozanimod, again, we see a nice safety signal with this in the sense that if you look at placebo in the middle column Ozanimod on the right column for different adverse events, you can see really that there's no difference between the two. So we have another nice agent on the horizon, oral, small molecule, but a different mechanism in an S1P that works very well in anti-TNF naive patients. Next slide. So let's transition into a topic that's hard to avoid in the last year, and I think this is probably something our patients ask us all the time. So Lucas is in remission on his current therapy, but he's worried about COVID-19 risks and the risk of COVID-19 infection, given that he's on immunosuppressive therapy, specifically infliximab. And what happens if he is exposed to COVID-19? Does he need to actually stop his medications? Next slide. This is probably the most common thing we're asked, and this is basically an IBD RAN panel. This was done early on that looked at SARS-CoV-2 and COVID-19. And you can see the statements on the left-hand side, basically looking at the risk of infection, risk of COVID-19, and you can read down to the bottom where it gets into should patients stop the medications. Just to go through the boxes just very briefly, this is based on an expert panel of physicians who treat IBD. So this is just what's the assessment of those physicians in whether they would stop medicines or whether they think the medicines are related. And so you can see the red is inappropriate, meaning that we don't think there's an association with these medicines and COVID-19. And just to very simply put this into context, aside from the prednisone dose over 20, a patient with a patient with IBD walking around in the world of COVID today on any medication is not at increased risk of getting COVID-19. All high-dose steroids, which we always want to avoid, may be the signal. Next slide. So this is the Secure IBD registry. For those out there, you're very familiar with this, but this is actually patients who have IBD, COVID-19, and essentially is a registry that's increasing as time goes by, and I think has been extremely informative. And this is looking at effectiveness, the effect of anti-TNFs and thiopurine on COVID-19 severity. So look at Lucas, who's on monotherapy anti-TNF for the minute. That's actually the smallest bar on the left-hand side. So being on anti-TNF monotherapy did not increase the severity of COVID-19. Thiopurines, you do see a signal, which we see with all viruses, and combination is really no difference, and it's probably the thiopurine signal, which we've known for some time with thiopurine in viruses. So anti-TNF alone and the anti-cytokines, I can say, do not increase COVID-19. Next slide. What about IL-12/23? Again, this is just a different way of looking at IL-12/23 and the anti-integrins. If you concentrate on the p-values, but the actual odds ratio, you can see the confidence intervals cross 1. They're very large. So this is part of the problem with the study is we have a small sample size, but the bottom line is we do not see an increased risk with either ustekinumab or vedolizumab in terms of severity with COVID-19, and we should not stop our therapies just because of COVID-19 and walking around in the world of COVID-19. Next slide. So this is looking at the risk of severe COVID-19 with tofusetnib. And again, this is a low number of patients, so that's always a caution in terms of interpreting this and analyzing this. But the bottom line is we do not see a clear signal either with Tofa. And again, I think we need to pause and wait to see over time. But I'll just tell you up front, if I have a patient on tofusetnib doing well, I do not stop that therapy just because of COVID-19 being in the world. Next slide. So what happens with Lucas? He actually is exposed. In this day and age, we're seeing more and more patients who are exposed to COVID-19. He tests positive for COVID-19, but they're fairly mild. He just has a little bit of fatigue and a sore throat, which is not uncommon to see in our younger patients. And then the question is, how should we manage his ulcerative colitis? Should we continue his treatment? Should we stop the treatment? What are the evidence that looks at this as well? Next slide. So look at the bottom two rows. This is really getting at if a patient tests positive, but they don't have COVID-19 disease, so they're SARS-CoV-2 positive. So for example, people often ask, what scenario would that be? Well, a lot of schools now will test asymptomatic. We test some of our patients for procedures who are asymptomatic, and they find out that they have SARS-CoV-2, but they have absolutely no symptoms. That would be that group of patients. And then the final bottom row are the patients who have active symptoms of COVID-19. So Lucas falls into that, although his symptoms are mild. And you can see the recommendations, at least based on the RAND panel, were not to stop the 5 ASAs. Veto gained a yellow, it's kind of uncertain. And then you can see for the anti-cytokine therapies, the thiopurines, methotrexate, the recommendation was to stop. But let's go to the next slide. I think we need to be a little bit more personalized in this, and I really like this slide. So this is restarting immunosuppressive therapy in patients with COVID-19, and this is Corey Siegel put this together. This is a way to conceptualize. So for those out there that wonder, and I do this, and I actually have seen more COVID-19 patients with IBD who actually are doing extremely well in terms of no COVID-19 symptoms, and I'm actually not stopping therapy or I'm not holding it very long. So on the y-axis is IBD severity, from very severe to mild. And then on the x-axis is mild, moderate, severe COVID-19. So if you imagine for a minute, look at the bottom left-hand side, a patient who has severe IBD but mild COVID-19, and that would be Lucas. The question is, if he's on an infusion-based therapy, you may not need to hold it because based on the timing of their infusion, he may not be due for it tomorrow. Now, if he is due for it tomorrow, he is COVID-19 positive, and he has mild symptoms, you can see that we should pause, but we don't have to stop it necessarily for 2 months or 28 days, which is often the recommendation for some other medical procedures and therapies. He's somebody that we probably would need to pause just for a week and then restart it, and we'll get to that in a minute. Conversely, if you have a patient with very severe COVID-19, look at the far right-hand side, but mild IBD up top, that's a patient that you have to decide, do you wait on therapy? I will tell you more and more, I'm actually not stopping my IBD therapy aside from the high-dose steroids because I worry about immunogenicity on monoclonals and I worry about flare of their IBD, but we have to individualize this to each patient. Next slide. So when to restart therapy, again, this is a really nice summary. If you don't do it based on testing of COVID-19, that's on the left-hand side. So imagine your patient where you're wondering, should I restart their infliximab or their other anti-cytokine therapy or tofusetnib? If it's been greater than 72 hours since recovery, and that's a resolution of their symptoms, and they have no fever-reducing medicines, and there's improvement in their respiratory symptoms, and it's been more than 10 days since their first symptom appeared, so it's basically 10 days, you can resume therapy. You should restart it. And I'm be honest with you, I've even become a little bit more aggressive and not even waiting that long. But I think that gives us comfort, and Lucas certainly would fall into that category. And if he's not due for his dose and it's more than 10 days, certainly it would be reasonable if he's resolved to continue. If you use a test-based strategy, that's on the right-hand side in that green box, all parameters for non-test-based strategy apply, but ideally get 2 consecutive negative tests. I will tell you more and more, I'm not using a test-based strategy. I think that has to do with the specifics of our tests, sensitivity and specificity. And we have had patients who've repeatedly tested positive, and they've gone very long interval between doses, and I don't like doing that. So I usually use a non-test-based strategy for my patients. Next slide. So this is a nice summary. This was adopted from the Gastro paper in 2020. You may have seen this before. And then on the far left, if you look at the first question, do not withhold or should we withhold therapies? Do not withhold IBD therapies. Try to reduce steroids if there are no symptoms, no testing. If you move further to the right, they have no symptoms, but they're positive for SARS-CoV-2. So now they have SARS-CoV-2 positive, they're asymptomatic. Again, you get into that 10-day window. If they're doing okay, they resolve their symptoms, they're not progressing, it's been longer than 10 days, We should not withhold therapy longer than 10 days. And I've said a minute ago, I've even gotten more aggressive and restarted prior to that time. However, if it's a patient moving to the right in the red who's positive for SARS-CoV-2 and has symptoms of COVID-19, I think we need to hold the therapy and see how they do. Again, this is where we have to individualize the severity of their IBD. That's why I like that graph that looked at that arrow going up. And then getting into the convalescent phase as far as when do we actually restart. If you remember 10 days and not having any symptoms or fever for more than 3 days, I think that to me is kind of the rule of thumb, that 10-3, 10 days since the start of the symptoms and at least 3 days without a fever or significant progression of symptoms. That's just a simple way that I look at it. This is a very useful guide, though, for COVID-19 and IBD. Next slide. And I think we might be coming back.
Yes. Thank you, Miguel. That was a fantastic presentation. I think, the fact that we have more data now is very reassuring for clinician and our IBD patient in terms of maintaining therapy that's keeping the disease in remission for our patients with IBD and getting guidance on what to do if a patient developed COVID. And I think you did an amazing job really, kind of breaking it down in terms of symptoms, disease severity, and what kind of therapy we're using and how long to hold it. I have to say, I've been seeing now more of patients with inflammatory bowel disease testing positive for COVID now, as opposed to early in the pandemic. And I'm wondering if this is what you're seeing also. And I'm encouraged by the fact that most of our patients seem to be doing very well, even those on immunosuppressive drug. And I've had also a tendency not to postpone therapy for too long, especially in patients who have kind of a tenuous control of their disease. Those that tend to have symptoms if they miss a few days of their injection or infusion. I think avoiding an IBD flare and a trip to the emergency room is always high in the back of my mind, and that becomes my priority, especially if the patient is asymptomatic or very mild symptoms. Are we all back together, or am I alone here?
I think the vaccine came up. I don't know if you wanted to talk about the vaccine at all.
Okay, don't leave me. But I want to, now in addition to managing IBD in the area of COVID, the next step now, of course, the hot topic is vaccines. And Miguel, you were with us and you shared your thoughts with us when we did a conversation on Monday Night IBD, really going over the vaccines, and you were very kind of forceful into, yes, we're going to recommend the COVID vaccine to our patients with IBD. But I would love to hear your thoughts, Miguel, first about the main questions that come from patient and concern. And I can summarize them into this vaccine was not studied in patients with inflammatory bowel disease. How do I know it's going to be effective, especially if on therapy that affect the immune system? And what should I do about my therapy? Should I hold off on my injection or infusion? Should I stop my thiopurine? I would love to hear your thoughts on this.
Yeah, so I mean, these are questions now that we get daily, and depending on the state you live in, the patient may or may not have access to the vaccine. So this might be that they're waiting for that, but they haven't had it yet. And then other states, our patients are starting to get this. I think it is true, the studies, the trials did not include patients on immunosuppression or IBD, so we don't have evidence-based data. We can extrapolate potentially from our immunosuppressive data in the past with other vaccines like pneumococcal pneumonia and the Pneumovax specifically. And I tell them there may be a decreased efficacy. We don't know. It's an mRNA vaccine, so it's very different than what we've had before. And I tell them if it decreases from, say, 93% to 85%, that's still pretty good. So let's just assume the worst case scenario, the efficacy goes down, which we don't know that it will. That's still pretty good. I do not stop their IBD therapies. If you had the magic wand of timing and they're on an injection or an infusion, and they can time it. Most patients can't time it, like all of us. I'm about to get my second vaccine this week, and I don't want to change the day despite it being in the middle of a busy day. I tell them, go ahead and get it. regardless, whether it's after an infusion or not. The only exception I do tell them, if possible, is not to get the vaccine on the exact same day as the infusion or the injection. And it's not because I'm worried about an interaction. It's just if they have a reaction to one, especially the second vaccine, that's probably where we see it the most. We don't know if it's the biologic they're reacting to or the vaccines, probably the vaccine. But to avoid that, I tell them just to go ahead. So really don't limit it. Tell them to get it. And so far, the data we are seeing is good.
I agree with you. I always remind patients that the vaccine we're using, like the flu shot and the pneumococcal vaccines, were not also initially studied in patients with inflammatory bowel disease, and the experience show us that they are effective, even if they're less effective if patients are on infliximab or combination therapy. It sounds like the data is a little bit better in terms of efficacy if patients are on ustekinumab or vedolizumab for a prior vaccination. And this vaccine has already a high efficacy to what we usually use. I mean, the flu shot is like 50-50, right? This vaccine is already, success rate is much higher. So yes, I agree with you, Miguel. Even if it's a little bit less, that's still good efficacy, and putting the risk and benefit of getting COVID and the consequence of COVID versus getting the vaccine. Definitely get the vaccine and don't delay the vaccine. Millie, back to you. Any other concern that your patients bring up? And I know you and I had talked a little bit offline about allergic reaction, things like that. But also going back to Miguel's presentation and showing maybe a signal for more severe COVID in patient on thiopurine, and including on combination therapy. Are you considering removing thiopurine in your patient who are stable on combination therapy, or is this changing, your practice in some ways, or is our priority always, let's control the IBD disease, because as long as our patient is in control, they can be safe and away from hospital and ER and away from steroid use, which obviously has the highest signal in terms of severe consequences and severe COVID. Would love to hear your thoughts on that.
Sure. And so I'll just briefly say that my practice has dramatically evolved over the course of the pandemic. Early in the spring, when some of these signals came out about thiopurines, my patients on combination therapy, I did back some of them down to monotherapy. But unfortunately, many of them developed immunogenicity and flared, and that was a worse consequence. And so I do no longer drop combination therapy. My patients who are on combination therapy are on it because they need it, and I continue that, and I will continue that during vaccination as well. And as a plug, I am one of the investigators on a patient-facing cohort called IBD Partners, which is worldwideweb.ibdpartners.org. And any patient can go to our site. And starting next month, we're actually launching a huge study where patients who have received the vaccine can report immediate side effects. They can report flares of their inflammatory bowel disease, which is a concern for some of our patients, although I'm hoping the data will demonstrate that that is not an association. And importantly, they can also go to LabCorp and get quantitative titers. We can tell how much of a titer they get, and we can do that over time so patients can know how high they responded and have some of that information. So I would encourage your patients to check out the IBD Partners site. We have a banner up saying coming soon, and they'll be able to register specifically for that study. And hopefully we can get this information very quickly in regards to an autoimmune population, how we respond from both an efficacy and a safety standpoint.
Yeah, that's fantastic. I think a lot of patients will be, I think a lot of patients are looking forward to knowing that they're developing a good immunity.
Right.
Yes, absolutely. Thank you. And I'll tweet it out when we're done.
Good.
Miguel, I'd like you to have the last word. We had a fantastic conversation today, and I want you to leave us with some words of wisdom as we're heading into this cold weekend. What is the take-home messages you think we should go with after this session together?
Yeah, so I'll give you some take-home messages, and then one maybe a bit provocative statement to end the session. But I think the take-home messages, at least from my part, is there's great hope on the horizon with more therapies coming for our patients and different mechanism of action. The other is that we are now living in the world of COVID-19, and I think it's going to be here, whether it's forever or for a long time, and we don't change our treatment for IBD. I agree with Millie completely.
I learned.
We should not stay away from our treatments. And then the final, maybe provocative statement that I wonder about, Millie, will be interesting to see in your study, as the second dose of mRNA seems to be very immune activating. And some of my colleagues actually have had to take off a day of work after that second dose for this maybe cytokine response. I wonder if some of our anti-cytokine therapy patients will actually have less of that kind of immune reaction, that immune side effects. So it's a silver lining I talk about with some of my patients. Maybe you aren't going to get sick. Obviously, then it gets into the efficacy question, but maybe that's actually a silver lining for anti-cytokine. Not to start anti-cytokine therapy for the vaccine. Please don't tweet that out. I'm not saying that, but you know what I mean.
That's fantastic. That's a perfect way to end it. And I'm glad there's data being collected for our patients with inflammatory bowel disease. I think is going to be really helpful when they're making decisions, and very reassuring. And I think having informed conversation between us and the patient is really going to have to help drive this forward and get everyone vaccinated and hopefully get back to some normal life and have a session like this, face to face, hopefully in the not too long future. I want to thank you both for spending the morning with us. I know we went over time, but this was such an amazing conversation with amazing IBD pearls. And I was taking notes, and I'm like, I have to tweet this later because I learned so much spending this morning with you. So I really appreciate you giving the time and the energy and for this webinar, and I hope we can do this again soon. So thank you, and have a great weekend.